So you are watching a case of chronic tonsillitis. She is a 60-year-old female having the problem of tonsillitis for long, and now we have planned a coblation tonsillectomy for her. So first we are holding the medial mucosal surface of the tonsil with the Alice forceps. We will use the coblation wand by Smith and Nephew EVAC 70. We will use the wand at a setting of 7 and 3. By pulling the tonsil medially, we will first identify the lateral margin of the tonsil. For the coblation to work, irrigation is very necessary. As you saw, the wand will not work without the proper irrigation. Now, I will begin my mucosal incision. I will take the incision just at the anterior pillar or a little lateral to the anterior pillar so that I can remove the tonsil completely without leaving behind any tissue. I am taking the incision on the lateralmost part. First, I will identify my plane, which will be completely avascular and there will be no bleeding whatsoever. So my first step after the incision will be to find out the proper plane. To make the image more central, now you can see the entire tonsil. You can see the tonsillar tissue which are coming out, the cotyledons. I am cobbleting at the same time little bit of the minor oozing that is occurring to make my field bloodless. Now after removing a little tissue, I will again rehold the tonsil, and now you can see the plane properly. I will divide at the junction of the cotyledon and the fibrous tissue. We have to prevent the damage of the fascia over the muscle layer. We have to stay as close to the tonsil as possible to prevent opening up the fascia, as if the fascia is damaged, the patient will have more pain in the post-operative period. So our aim is to prevent the exposure of the muscle, and that is done by preventing the fascia to open up. We will use the coblation just near the tonsillar tissue. We have to open the tonsil like a book, and you have to use traction and counter traction to see the plane properly. I am extending my incision inferiorly. Now in this step I am cobbleting in the course of the tonsillar artery. This step helps us to prevent bleeding while cutting the tissue. As I have already cobbleted, there is very less chance for the tonsillar artery to bleed. The another method to prevent bleeding from the tonsillar artery is to go intracapsular at the lower pole. As you can see, we are completely extracapsular from the top part. Now we can go a little bit of intracapsular at the area of tonsillar artery to prevent it from opening up. We will just leave a sleeve of tissue over the artery, and we will also coagulate that area so that no active lymphoid tissue will be present. We constantly have to maintain the traction and reposition your grip according to the area you are working on. In the area of the lower pole, the tonsillar tissue will always be more firmly adherent to the bed, so it will be a little difficult at the for the dissection at the lower pole. So always do a prophylactic coblation, means coagulation at the lower pole, so that the tonsillar artery does not get open up. As you can see, there is absolutely no bleeding at the site of dissection. There is minor mucosal bleeding from the tonsillar medial surface from where we are holding due to the trauma due to LS forceps, but there is absolutely no bleeding from the tonsillar bed. So we can say this is absolutely a bloodless tonsillectomy. Now we are almost over with our dissection. We will now separate the tonsil at the lower pole. The tissue at the lower pole is little bit stiffer and more firmly adherent, so it is always difficult to remove it. And in an adult patient, because of chronic tonsillitis, the, uh, the tonsil also get fibrosed, so it becomes adherent to the surrounding tissue. And it is this area where the tonsillar artery is present, and it will get open up more commonly in this area. So we have to be a little extra careful. We will see our lateral limit, that is the fascia, when its color changes to brown. So when the fascia color changes to brown, it is our limit. We get an idea that we don't have to go more lateral to it, and we are preventing the opening up of the fascia. You can see a whitish layer all over the tonsillar bed, and there are no muscle fibers that are exposed. See, some fibers might get exposed as it is an extracapsular tonsillectomy and not intracapsular tonsillectomy. So some of the fibers will get exposed. It is inadvertent, but at the maximum area, we have preserved the fascia. Now we will separate it from the bed. There is only a stalk which is attaching the tissue with the bed. And see, there is absolutely no bleeding from the tonsillar bed after the tonsillectomy. And there is a sleeve of fascia present over the tonsillar bed. We will do a little bit of coagulation just to be sure there is no postoperative bleeding. I will ablate a little bit of the lingual tonsils, which I can see. So this is for this video. Thank you for watching.